Hello and welcome to today's webinar. On behalf of the NIOSH-supported education and research centers throughout the country, we're pleased to present the 2019 Ergonomic Webinar Series, offering free monthly webinars on various topics on human factors in ergonomics. This collaborative effort on behalf of each ERC's continuing education program aspires to provide access to current research supported through NIOSH ERC programs. Thank you so much for joining us today. In today's webinar, Mechanics of Human Lower Back Pain and Occupational Low Back Pain is brought to you by the University of Kentucky Central Appalachian ERC and Dr. Babak Bazrgari. A few housekeeping items first. You'll be muted during this presentation. If you would like to ask a question, please enter it into the online chat or Q&A. We will save time at the end of the presentation to address questions. This webinar will be recorded and is archived for viewing on COEH Northern California's website, Facebook, and YouTube channel. At this time, I am pleased to welcome our presenter, Dr. Babak Bazrgari, PhD. He's an associate professor of biomechanical engineering at University of Kentucky, where he also directs the Human Musculoskeletal Biomechanics Lab. Dr. Bazrgari's research in the biomechanics of human musculoskeletal system focuses on spine and low back biomechanics. Thank you so much for joining us today.
Thank you for the nice introduction. Good afternoon, everyone. So in today's webinar, I will be presenting biomechanical studies that we have been doing on human lower back. And for that reason, I will be talking a little bit about low back pain because most of our studies have been motivated because of the relevance between mechanics of human lower back and low back pain experience in individuals. My hope is by that presentation, by that overview about low back pain, to highlight the research gap to which we are trying to contribute in our research. And then I will talk a little bit about the actual focus of our research as related to that research gap that I will be highlighting in my talk. I will talk a little bit about some of biomechanical methods that we use in our research, and I will end with a couple of slides about our current ongoing research. So to begin about low back pain, I'll try to give two different perspectives about low back pain, one occupational perspective and the other clinical perspective. From an occupational perspective, low back pain is considered to be a significant musculoskeletal disorder. And for that, and it might be better to be referred as low back disorders because a lot of information that highlight the significance of this problem at workplace are coming from epidemiological studies wherein this problem is defined differently, ranging from a trouble or a discomfort at lower back to an actual injury in the lower back. So stemming from these epidemiological studies, it is clear that low back disorder is very prevalent at workplace. And there are reports of, like, in terms of lifetime prevalence of low back disorder to be as high as 80%, like suggesting that pretty much most of workers experience low back disorder during their work life. Also, when looking at labor statistic data, one can see that occupations and jobs that are associated, that are very physically demanding, the incidence of low back disorder is high among them. But again, equally, low back pain is seen and reported in occupations that are not physically demanding and are pretty much sedentary. As far as it relates to the cost associated with low back disorder at workplace, there are costs associated with missed work days, productivity loss, and if there is requirement for replacing the workers, there's going to be costs associated with worker replacement. Prevention of low back disorder at workplace is an extremely challenging task, and that's primarily because the exact cause of low back disorder cannot be determined. In such situation, the majority or maybe the most of prevention effort at workplace are focused on managing the known risk factor, work-related risk factor for low back disorders. These risk factors can be categorized as being like work-related and non-work-related. On the side of non-work-related risk factor, there are risk factors that are essentially personal risk factor. A factor like gender is identified as a risk factor for low back disorders because of the evidence that suggests the risk of experiencing low back disorder is higher among females as compared to males. On the other side, for risk factors related to like work-related risk factor, these can be categorized as either being physical risk factor or psychosocial risk factor. For instance, whole body vibration, which I think was the subject of a previous talk in this series, is a known risk factor for experience of like associated with low back disorder. And on the side of psychosocial risk factor, a number of factors have been identified. For example, stress, job clarity, and social support. These are considered to be known and established risk factors that have been associated with low back disorder at workplace. So in the absence of any knowledge about the exact cause of like different low back disorders that are observed, pretty much preventive efforts are being focused on managing exposure to these risk factors. From a clinical perspective, low back disorder is significant primarily at its chronic stage. And low back pain is considered or defined as chronic depending based on the duration of time that symptoms have been present. There are different definitions out there in terms of what is chronic, non-chronic, or acute or subacute low back pain. But the most recent definition by NIH suggests that if the duration of symptom if the symptoms have been present for more than the time during the past 6 months, the low back pain can be considered as chronic low back pain. At its chronic stage, low back pain is considered to be a leading cause of disability. It is also associated with opioid abuse. Similar to prevention challenge, treatment of low back pain is challenging because most low back pain cases that are seen by physicians, it is not possible to determine what is causing that specific back pain case, and they are being categorized as non-specific low back pain. So in this situation, there are a number of treatments available, and pretty much the effects of these treatments on a given patient is being guided by the symptom, by the effects on the level of pain and disability. But a good thing about like clinical aspect, like perspective for low back pain, is that the clinical course of low back pain is pretty much for most of individuals is favorable, and after a few weeks they get recovered regardless of like what type of treatment they are receiving. So here I wanted to show a fellow chart that is like, a suggested guideline by the American College of Physicians as well as the American Pain Society for treatment of patients with low back pain. So early on in this guideline, like a given patient is being screened for known or specific source of pain as well as like to rule out any red flag. Once that is done, and the patient is categorized as non-specific, meaning like the specific cause cannot be determined, the practice will involve asking the patient to stay active and get pain medication if needed. And then if the patient is not getting better, then what I want to bring your attention here is this loop on the right side, that this is the patient will pretty much get into a trial and error effort where they are being like, given different type of treatment. Hopefully they respond to one of these treatments. So our current condition in terms of management of low back pain, whether at workplace or clinically, is as follows. At workplace, preventive efforts are primarily focused on managing exposure to risk factors. For example, to reduce or eliminate exposure to risk factor. The treatment efforts are primarily guided by the impact of treatment on the symptom. And when we look at systematic reviews, result coming from systematic reviews of intervention that have been tried for preventing low back disorder at workplace, or to look at efficacy of treatment offered for low back pain clinically, the outcomes of these systematic reviews are not satisfactory. And one reason for such unsatisfactory outcome is a lack of knowledge about what are the links, whether it exists between what we know and a person's like experience of low back pain. We know a lot about risk factors that are associated with low back pain, but like, how they are related with an individual's or a worker's experience of back pain, it is not clear. And on the clinical side of it, there are treatments that in fact get some patients better, but they're like, they cannot get or provide benefit to a large group of patients. So this is actually, this gap is an area that we are trying in our research to which to contribute. So with that brief background, I would like to now a little bit elaborate on our research focus. To further clarify, like where exactly we are trying to focus our research, I would like to bring to your attention that in an individual's experience of low back pain, there's going to be three important elements. One is going to be a source of pain, and there's going to be a sensing element, and also an interpretation that is happening inside the person's brain. So what we are concerned in our research is that the low back pain that is, like, we are concerned about the source of low back pain that is located inside the lower back. So we are not concerned about low back pain that the source is outside of the back and is being interpreted inside the brain as a low back pain. This type of pain is being referred as referred low back pain. We are also not concerned about perceived or interpreted low back pain that are because of some disorders of nervous system. For instance, in chronic low back pain patient, there's the possibility of this central sensitization, wherein the sensing system or the nervous system can remain stimulated even in the absence of any source for the pain. So our focus is primarily on potential source of pain within the lower back, and actually mechanical source of pain. And that is because lower back tissues are very well innervated tissues, particularly as related to the spinal column. Here I borrowed a picture from White and Punjabi's book, and as you can see, intervertebral disc and facet joints, these are all well innervated structures, and there are evidence out there that shows mechanical loads, excessive force, excessive deformation can either directly and indirectly stimulate these pain-sensitive nerve endings and result in experience of low back pain. So in our research, we are trying to provide an accurate estimation or quantification of lower back environment, the force and deformation that is being experienced in the lower back tissue. And as related to occupational low back pain, we are interested to see how workplace factor, for example, the identified risk factor for low back disorder, affect mechanical environment inside the lower back tissues. So I need to describe a little bit about how we see mechanical load inside the lower back and how these are determined. The load that are experienced, force and deformation experience in the lower back tissue is directly determined by the equilibrium and stability status of the spinal column. So I tried to explain them a little bit more to just provide more information. Spine equilibrium is a balance between two sets of force. Force that are inserted on the spine by the internal trunk tissue, muscles, passive tissues like ligaments, and external force, making the other set of force that is due to the weight of the trunk, weight of the hands and head, and also if these structures are moving fast or there is some inertial component, forces due to inertial demand of these components. And if the person is having a physical interaction, like lifting a load, the load and inertia demand due to that, manipulated load. So the balance between these two sets of force around the spine is defined to be a spine equilibrium. And as you can see, because when an individual will perform an activity, they should generate enough muscle force to be able to perform that activity, and because of the stretch or deformation of their spine, that this other passive tissues that they cannot generate active force, they also being involved in providing that equilibrium. And these force inside them, being considered loads inside the lower back tissue, is being affected by the equilibrium of the spine. As related to spinal stability, the stability of a spine is defined as a quality of spine equilibrium. So there are different definitions for spinal stability in the literature. There are the clinical definition of stability is quite different, and they are based on information coming off images obtained from patients. But what we define as a spine stability here is the characteristics of spine equilibrium. And that's the capacity of the system that provide equilibrium to the spine in sustaining that equilibrium condition despite internal and external perturbation. So to explain more how stability of spine will affect the load experience inside the lower back tissue, let me just give you an example. If a person is required to lift the load from the floor, from an equilibrium perspective, if the person requires to generate enough force inside the muscle to be able to move the weight of the trunk, head, and hands, as well as the weight of that object, and then being able to move it, move them upward altogether. So the force inside these muscles will determine the muscle force, going to represent muscle forces. The force that are inside the ligaments due to stretching will be the force that is seen in the passive tissue, and the vector sum of this internal and external force will be representing a spinal load, force that are being seen inside the spinal tissue. But if that object that is being lifted by the person is, let's say, a stable object, for instance, if it is a large bucket of liquid, that as soon as it is being lifted from the ground, the liquid will start moving around and just applying continuous perturbation to the system, then the trunk neuromuscular system will adopt a stabilizing strategy, by, for example, strengthening the core muscles, by activating and co-activating by not only activating extensor muscles, but abdominal muscles. That co-activation, that strengthening of the core would result in experiencing much larger load as needed for just simply satisfying equilibrium requirement of the spine. So with that description about what we mean in terms of load experience in the lower back, here's how we study, how we just look at in our studies, in our research study lower back mechanics. We not only characterize load experience in the spinal, in the lower back tissue, but also we try to characterize the contribution of these different important elements into the spine equilibrium and how they affect the load experience in these different tissues. So if I describe this differently, when an individual want to perform the activity, let's say lifting here, the person will activate the trunk muscle, and depending on how they activated the muscle, they will adopt a specific work method. They might just just adopt a unique lumbar posture, adopt a unique lifting technique. And then depending on that posture and motion that they are adopting, their passive tissue will be stretched or deformed differently and will contribute differently to the equilibrium and stability of the spine. So as a result, you can see these all different components contribute to equilibrium and stability of the spine and influence load experience in the lower back tissue. So in our research, we try to see how these different components contribute to the load experience inside the lower back tissue. And also, we try to understand how exposure to different risk factors is going to affect these contributing elements to a spine equilibrium and stability, and what's going to be the resultant impact on load experience in the lower back tissue. So with that background about our research focus, I'm going to just present a few of biomechanical assessment methods that we are using in our lab. I will start by talking about how we evaluate load experience inside the lower back tissue. As it is possible to do measurements of lower back tissue loads, but that is extremely difficult, and there are significant ethical considerations. And for that reason, there is a lot of like using biomechanical models have become much more attractive for researchers. And looking into the literature, there is a wide range of biomechanical models that are being used for studying loads in the lower back tissues. These range from simple rigid body link segment models that they provide information about the physical and mechanical demand of an activity on the lower back. They do not provide information about the internal tissue response. These, like one level higher, some of these rigid body models are being integrated with some muscle models to just get some estimate of how much muscle force are needed to balance that mechanical requirement of the task. And then a level higher, there are some models that, in addition to muscle, also they consider contribution of deformable body, ligaments or passive structures in equilibrium stability of the spine. These models pretty much work on the basis of inverse dynamic method, and the input to these models are motion and force measured during the experimentation, and the output's going to be either the moment at different level of lower back or spinal column, as well as required muscle force, or deformation or force generated by the passive tissues. And majority of them are working on the basis of consideration of spine equilibrium. There are a few studies that have considered stability requirement in estimating load inside the lower back. The model that we use in our research is the model that originated in Dr. Shiraziad's lab in Montreal. And it's a finite element model of the human spine and trunk muscles. And for those of you who are not familiar with the finite element models or method, it's a method for studying force deformation behavior of structures that have complex geometry, complex material property, or nonlinear properties. So in this model, we simulate spinal vertebrae as rigid bodies, and the contribution of passive tissues, ligaments, and intervertebral disc using beam element, and also the mass and mass moment of inertia of trunk segment are being represented by point masses. The specific contribution of ligamentous spine are coming from experimental studies that have tested the spinal motion segment pretty much being two vertebrae, the disc in between, and the ligaments that surrounding them. And from these experiments, as you can see here, information about the passive response, let's say flexural rigidity of these motion segments in response to rotation of the segment or bending of the segments are characterized, or their axial deformation in response to axial compression. So these mechanical properties obtained from experiments are defined in that finite element model of the spine. A rather complex muscle architecture is being considered in this model that we are using. It includes 56 muscles. Some of them run from thorax region all the way to the pelvic floor, and some others run from different lumbar levels to pelvic floor. In our simulations, so in the literature, most of models of lower back, spine, and trunk muscles, they consider a constant moment arm or acting moment arm for muscles. Since we have actual muscle element in our simulation, we can account for changes in moment arm of the muscles. And also we can also represent muscles more realistically and just consider as curved line instead of just a straight line in our simulations. We implement this model in a kinematic-driven approach or method that we call it, wherein we use measured movement of the trunk segment as well as any external load that is being applied or lifted by the person, and we prescribe them onto this model. And through an iterative procedure, we get estimates of required muscle force for an individual to perform that task or activity. And also, we get some estimate of the amount of contribution coming from passive structure in such a spinal equilibrium condition. In doing so, we make sure that the equilibrium requirements are satisfied across the lumbar spine rather than just one spinal level. So to give you an example of how we have used this, one of the studies that we used using this model was to study the effect of different lifting techniques on loads being experienced in the lower back tissue. We asked 15 individuals to perform 2 different types of lifting. To lift a 40-pound load, either using squat, which is actually a knee lifting method, and a stoop, which is a back lifting method, to see how these different lifting techniques are going to impact the load experience in the lower back tissue. Coming from our model, we were able to determine the mechanical demand of each of these lifting techniques on the lower back at each level of the spine. So here, what I've presented here is the net moment or mechanical demand of the task at the S1 level of the spine. So as you can see here, that demand of the task increase as individuals bend forward, and that the demand of the task is larger for the back lifting or stoop lifting, and that's because as they require to bend further forward, and as they bend forward, the center of mass of the trunk, as with respect to the S1 level, is become further away, and the acting moment arm of these gravity force is increasing with that movement. As soon as they pick the load, there's going to be a sudden increase in the demand of the task, and as they come back upward, the net moment demand of the task is decreasing. The passive contribution of the spinal tissue to that task, as you can see, is just a function of the amount of deformation that they are experiencing. And since stoop lifting, back lifting type is associated with larger trunk flexion or lumbar flexion, you can see the contribution of passive tissue, ligamentous spine, is much larger under stoop lifting as compared to the squat. So the difference between this net moment of the task and the passive tissue contribution is going to be what should be supported by the muscles. So we will have this net moment predicted by the model for each level of the spine. And in the post-processing, we try to distribute that moment that should be balanced by the muscles at each level by the muscles that are attached to that level. So to give you one example, here is the moment that should be balanced by the muscles that are attached to the thorax region. And this is the moment that is observed at the T12 level. And since the predicted moments are pretty much extensor moments, in our calculation that is optimization based, pretty much the force predicted were in the extensor trunk muscles, iliocostalis and longissimus. And as you can see here, I have put 2 different set of lines here. One are broken line. These broken lines represent the passive contribution of these muscles into this, just balancing that moment requirement, and are actually a function of deformation of the muscle or stretching of the muscle, and independent of the optimization procedure that we have implemented. Once we calculated all the muscle force, passive tissue contribution, and we have the knowledge of external demand of the task, calculating a spinal load is going to be a simple matter of vector calculation or vector summation of these force. And I have presented here the compression force seen at the L5-S1 level of the spine for both stoop lifting and squat lifting. What I want to emphasize here is the load that this subject lifted was 40 pounds. And this is actually 10 pounds less than the weight of load that is being considered to be safe for luggage handlers. And under that load, you can see the compression force experienced at the L5-S1 reached to about 5,000 Newton. and the shearing force to 1.5 kilonewton. As related to compression, this is near the reported threshold of injury, the range of threshold of injury for the spinal vertebrae. For the shearing force, it is within the reported range of threshold of injury. So even for this below, or like a lifting of a load that is considered to be safe, it is possible if a worker doesn't have a good physical fitness to get injured with even below safe limit of load. We also used some indirect method for the assessment of spinal equilibrium and stability, or for the assessment of contribution of tissue, active and passive tissue, into spinal equilibrium and stability, that I will talk about a couple of them in this presentation. One of the methods that we use is to study lumbo-pelvic coordination. Is we ask a participant to perform a simple trunk forward bending and backward return. This is a standard clinical assessment method that is being used by clinicians for assessment of neuromuscular control of trunk motion. And we also use it to get some estimate of different aspects of lumbo-pelvic coordination that I will talk about them briefly here. In this test, we usually ask our participant from a standing posture to bend to their maximum comfortable bending posture as we measure the rotation of their pelvis and thorax. And then ask them, and they will be asked to do this, the bend forward and come back at their self-selected pace, but doing it once at a slow pace and at a fast pace. And from measurement that we have, changing the angle of the sensors that is attached on the pelvis from the standing posture will be considered to be pelvic rotation, whereas the change in the angle of the other sensors is considered to be thoracic rotation. And the difference between them is going to be considered to be the rotation of lumbar as a single joint. So here are a set of sample results for rotation of thorax, pelvis, and lumbar under a slow-paced and a fast-paced forward bending and backward return that has been repeated 3 times. So here, as you can see, the thorax, which is the larger rotation that is being observed here, and the smallest one being pelvic rotation, and the difference between them representing the lumbar deformation or lumbar flexion or lumbar rotation. From this measurement, we can get some estimate of, in terms of magnitude aspect of lumbo-pelvic coordination, and usually we characterize that by quantifying the percent contribution of either lumbar or pelvic into thoracic rotation at different time points. We usually consider report that ratio at the maximum flexion or at full bending posture. We can also get some timing information, but for doing so, we need to transform these kinematic data and translate them into a phase plane, and from there, obtaining the relative phase between thorax and pelvis as the person perform this activity. Coming this relative phase analysis, we can get some information about the whether thorax and pelvis segment moving in phase or out of phase, and how variable is that movement, to get some sense of neuromuscular control of that motion and stability of such a motion. Here are some of the results that are from a recent study that we completed to look at differences in mechanics of lower back between individuals of different age. In this study, we studied individuals from 20 years to 70 years old. And we did a number of different tests. One of the tests that we did was this trunk forward bending and backward return. And what I have presented here are the result in terms of thoracic range of motion, being that maximum rotation that we observed, and also the contribution of lumbar to that maximum rotation. As you can see, there are some differences in this the maximum thoracic rotation between age group, but these differences were not significant and were not different between male and female. But what we saw that was significant was the contribution of lumbar spine into that thoracic rotation. With increasing age, that contribution decreased, and it was also smaller in female as compared to male. When we ask a participant, like when we compared the slow versus fast movement, of course, when they did fast movement, they were able to achieve a larger forward trunk flexion angle, but then doing the task fast resulted in a reduction in the lumbar contribution. So how this might be related to an individual's experience, like the load inside the lower back tissue. I just want to compare with some of the results reported in a study published by Tafazol et al. In 2014. They looked at the effect of changing lumbar versus pelvis contribution into thoracic motion on a spinal load, on compression force and shear force experienced at the L5S1 level. So increasing lumbar contribution versus pelvis, they noted that is associated with decrease in the spinal load. But what we see here with increasing age, the contribution of lumbar is decreasing. So as you can see, decreasing lumbar contribution is associated with higher spinal load, both compression and shear force. And that happened, that is like, that we see that contribution is less in females, that they demonstrate higher incidence of low back disorder at workplace, and also is observed under a fast trunk forward bending and backward return. And then trunk motion has also been considered to be a risk factor. Another method that we use to study, in fact, the passive contribution of lower back tissue to spinal equilibrium is a passive stress relaxation test, and that we put the individuals in our sudden perturbation device, and we passively cause a flexion in their lumbar region by raising their leg around their hip joint and measuring them. Like as we raise the leg, what will happen? The trunk will be pulled backward by the passive stretching of the lower back tissue, and that tendency to move backward because the person is constrained is being recorded by a load cell that we have in the system. Here are a typical measured response. As we raise the leg, the passive moment generated by this tissue increasing, and then if we get them to that given flexion posture, lumbar flexion posture, and keep them there, there's going to be, because this is structure, the tissue, lower back tissue are viscoelastic, there will be a relaxation of these tissue, and then as we bring them back, the passive moment drop. Here we plotted them the moment, the passive moment versus flexion angle, to just provide some basis for calculation of stiffness. So we can calculate average stiffness during the loading period of the experiment, and also quantify the energy dissipated in terms of the area inside this hysteresis loop, and also a relaxation moment that occurred during this rest period in flex posture. So for that aging study that we did, we also completed this passive stress relaxation test. And as you can see, we expected this, that like older individual will have a stiffer lower back, and what we saw was confirmed what we expected. But what we didn't expect was that the older individual would demonstrate larger relaxation, and they will show like larger dissipation of energy, to the extent that after 4 minutes of like a relaxation period, their stiffness was not that much different from that of the younger individuals. So an implication that this might have is like, if there is an occupation that requires prolonged flex working posture, it is possible like, those activity, because of this faster rate of decrease in passive tissue contribution, might be more fatiguing for older individuals compared to the younger individuals. I will have just a couple of more slides about our current ongoing research. and then I'll be done with my talk for today. So this was the research design that we have been using in our research to study different occupational activity and see how they are affecting spinal loads, and also to study how exposure to different risk factor might affect these behavior in the contributing element to the spinal movement stability. And in fact, the major study that we did was to look at differences in age risk factor, how that difference is related to differences in behavior of these elements. Alternatively, another way to look into this is like to do these assessment pre-post exposure to a risk factor, and then also see like how they recover over a period. We did some of this study during my postdoctoral research at Virginia Tech. One limitation of this type of a study was that they were being conducted in the lab. The individual were exposed to just one single risk factor, and usually the participant or subject was not a representative of a working class. So we have made some changes into our research paradigm. Currently what we are doing, and we are studying nurses in this study, we are doing our biomechanical assessment before their work shift and after their work shift, and see how much disturbance or changes is happening in their lower back mechanics, or these measures that we have. By doing so, first of all, we are actually testing the actual workers, and then we are looking at the collective effect of all the risk factor, being physical risk factor or social risk factors, as well as we're also considering any possible personal differences in terms of physical fitness, psychological fitness might be present between these individuals. Once this is done, then at the next stage, what we want to do is to see if there is any association between what we have seen in terms of disturbance in mechanics of lower back and an experience of back pain down the road, and whether we can use these measures to inform early preventive interventions. The other study that I wanted to talk about is we recently completed a study of a patient with non-chronic low back pain. One of the things that we did, we looked at their lumbo-pelvic coordination during that forward bending and backward return experiment that we had. And these patients, that they were 20 patients with non-chronic back pain, we observed that for doing that activity, they implement larger pelvic contribution as opposed to the lumbar contribution. And this is consistent with what is being seen in the literature related to lumbo-pelvic coordination of patients with low back pain. But what was interesting for us was that they kept that abnormal lumbo-pelvic coordination despite improvement in their symptom, in their pain, in their disability. So what we're now trying to understand, like the studies that we are running, are to see if there is any association between that abnormality and recurrence of low back pain. Because as of now, what is being considered as a predictor for recurrence of low back pain is a history of low back pain. And that knowledge really cannot provide much basis for designing effective intervention. And with that, so I would like to wrap my talk by saying that the management of low back pain or low back disorder is a challenging task because of an inability to determine the exact cause of low back disorder for a given work case or for a given patient. But there are a lot of information out there that shows that forces and deformation inside the lower back tissue, they can cause experience of back pain. And there have been a lot of advances in recent years in terms of quantification or characterization of lower back mechanics, that these can be implemented to better characterize the impact of workplace factors or treatments on lower back mechanics, and hopefully eventually implement these knowledge to design effective intervention or more efficient treatments for low back pain treatment. And with that, I'd like to acknowledge the funding resources that we had and as well as contribution of my student into our research. And I'd be happy to answer questions.
Thank you so much for the presentation. As a reminder to the people in the audience today, you are able to enter any questions that you have into the webinar chat box. There's also an option to enter it into the Q&A box. And you hover over the webinar screen, those boxes should pop up for you. And please do feel free to enter any questions into there. First, we do have a comment. Someone wanted to say thank you for sharing all of your research with us. We also do have another question. They weren't sure if this is the right place to ask, but aside from engineering controls on prevention of back injuries in the workplace, they're seeking some direction on best body mechanics the worker can use when lifting or moving material, particularly as it relates to foot spacing and stance.
I'm not sure probably if I am the right person to answer that question. We've been studying factors that influence mechanical load inside the lower back, and there are parameters that can, implementing them when performing a lifting can reduce the demand on the lower back. So for example, the study on different lifting technique that I presented. So if a person can perform leg lifting or knee lifting, squat lifting, so that is clearly put less demand on the lower back, but doing that lifting is not always possible depending on the working condition. And there's also evidence out there that suggests as people get fatigued, there is a tendency to change their lifting techniques. So bringing load closer, anything that can reduce the demand of the task on the lower back would help reducing the demands. I think I would consider, from a mechanical perspective, to be a safer lifting technique.
Thank you. We have a couple more questions. Your biomechanical model suggests that compression and shear forces are higher in stoop, lift versus squat. They've seen some prior studies that suggest compression is higher in squat than stoop, and shear was higher in stoop. Have you noticed, or can you comment on any of these differences?
I cannot, based on these studies that I did, was a few years ago, and I do not recall seeing studies that have shown larger spinal load under squat lifting technique. But as I said, there are many factors that are involved, and for a given lifting condition, even maybe implementing a squat lifting technique might result in high, I cannot say larger than stoop lifting technique spinal load, but pretty much what the difference between these two lifting condition is that stoop is putting a larger demand on the lower back as compared to because of the moment arm of the both load and center of mass of the trunk. So I do not know if I was able to answer that question, but if this was a specific, I probably would have been able to better answer. So if there are a specific case, feel free to send email to me. I'd be happy to discuss them at a later time.
Great, thank you. We do have another question. Someone was wondering if there are any applications ready for use among medical providers who are treating low back pain.
Application for assessing mechanical loads?
If the person who asked that question wants to expand upon that, that would be wonderful. And the way I interpreted this question is if there is anything, I guess, any translations that you could take from your research into treatment options for lower back pain.
Probably not as of now. But if the application is in terms of spinal load, there are tools in the field of ergonomics, software tools that are being used by ergonomists for assessment of lumbo-pelvic coordination at workplace, for assessment getting rough estimate of a mechanical load at workplace that possibly might be able to be implemented in a clinical setting.
Great, thank you. We also have another question referring to your thoughts on emerging technology, for example, wearables and exosuits. They believe it's the current nomenclature in ASTM F45 or the American Society for Testing and Materials.
So I know there are interest in using this wearable technology, and this is considered to be a priority as far as I've heard, like, for example, for NIOSH, for implementing them for in-field assessment of risk for musculoskeletal disorders. But unfortunately, I'm not very familiar with application of those technologies.
Great, thank you. And if anyone else, we do have a few more moments if anyone wants to enter any other questions into the chat box or Q&A. And I do want to thank you again, Dr. Bazrgari, for being here with us today. We so appreciate your time and sharing your research with us.
Sure, it's my pleasure.
We have some more echoes of thank you for the presentation coming from members of the audience. And as far as access to the references, you are welcome to send us an email if you want a copy of the presentation slides, and we are going to be able to distribute those to people who attended the webinar today. Excellent. Well, thank you all so much for being here. A special thank you to our presenter and to all of you who joined us for today's webinar. Our next NIOSH ERC webinar will be Large Herd Dairy Milking Parlors, Exposure Characterization and Intervention Analysis on Wednesday, June 19th with Dr. David Dufresne from the University of Texas Health Science Center at Houston and Dr. Nate Fetke from the University of Iowa. COEH Continuing Education will also be having a webinar on electronics waste and human health on Wednesday, June 5th, featuring Jim Puckett, the director of the Basal Action Network, and Dr. Diana Caballos from Boston University School of Public Health. You can learn more and register for our upcoming webinars at coeh.berkeley.edu. You can also subscribe to our YouTube channel, where our recorded webinars are regularly posted. And if you do want a copy of the presentation slides, you can send an email over to coehce@berkeley.edu. And you can also, that information will be in your follow-up email that you'll get from us as well. Thank you so much again for being here, and I hope you guys have a wonderful day.